This week on the BackTable podcast.
I remember one patient specifically, when I was describing it, he was like, wait, so you're going to microwave my head? And I was like, no. Well, kind of, right? So radiofrequency, what it is, it's along an electromagnetic spectrum, right? So just like a microwave, except the wavelength's a little bit longer. And the idea here is that you're using radio waves to deliver energy, right? So kind of like, your phone. We have all these like MagSafe chargers now. Same idea there, right? You're using something along electromagnetic spectrum to deliver energy to charge your phone. In this case, you're kind of charging your nasal mucosa or those nerves, right?
Every week, ENTs see close to 20 patients with allergic or non-allergic chronic rhinitis who may not get lasting relief from medication. Most don't want surgery, and medical management often isn't enough. That's why there's Rhinair from Aerin Medical, market-leading technology that has been performed on over 50,000 patients to date. Rhinair is the only comprehensive, incision-free treatment that targets multiple anatomic contributors to chronic rhinitis, including the posterior nasal nerve, inferior turbinate, and septal swell body to deliver durable results. Starting September 15, 2025, Cigna Healthcare will cover Rhinair, expanding access for your patients. Whether in-office or in the OR, Rhinair can improve chronic rhinitis symptoms like cough, postnasal drip, congestion, and rhinorrhea with relief that lasts. Learn more at Rhinair.com or from your Aerin Medical representative.
Hello, everybody, and welcome to the BackTable ENT podcast. My name is Gopi Shah. I'm a pediatric ENT, and today I'm here with my co-host and bestie, Dr. Ashley Agan. How are you, Ash?
Woo-hoo, Gopi. Good morning.
Good morning.
I'm so good. Always so excited and happy to be across the mic with you. And we have a great guest today. Dr. Dennis Tang is joining us. He's a rhinologist practicing at Cedars-Sinai Medical Center in Los Angeles. And he's here today to talk to us about chronic rhinitis. Welcome to the show, Dennis.
Thank you so much. And thank you so much for having me. I've listened to quite a few of your episodes. I've always been really impressed by them. So very honored to be a guest on the show.
Absolutely. So tell us a little bit more about you and your practice.
Yeah, so I'm in Cedars-Sinai in Los Angeles. I'm a fellowship-trained rhinologist, so I just do rhinology, so endoscopic sinus and skull-based surgery. A majority of my practice is inflammatory, but I do a good amount of skull-based as well with our neurosurgeons. So it's been a great experience growing the practice at Cedars-Sinai.
So today we're going to be talking about chronic rhinitis. And to kick off the show, there's some recent coverage news in terms of coverage. Can you talk to us a little bit about that?
This has been a very exciting time when it comes to the treatment of chronic rhinitis. So there was this procedure that came out for chronic rhinitis called a posterior nasal nerve ablation. And so many of the private insurances have considered it experimental for a long time, even though it was being covered by the public insurance, by both Medicare and Medicaid. However, Cigna is the first private insurance that has officially come out nationwide saying that they will start approving this procedure. And so it's been a huge gain in getting this procedure a bit more available to our patients.
Yeah, so you're potentially got numerous patients who now will be able to have this covered by their insurance.
Yeah, exactly. This has always been the most frustrating part, right? Because there's been a lot of patients who wanted the procedure, who probably needed it, but their insurance just wasn't covering it, or they were denying it, saying that it's experimental. So to be able to give access to those patients is a huge win.
With Cigna being the first commercial insurance to start covering it, can we assume that means maybe the other big players will follow suit?
I hope so. We saw something very similar when it came to balloon sinuplasty about a decade ago, right? Where initially a lot of the privates were considered experimental, and then with time, with mounting and growing evidence, slowly one by one, they all start covering it.
So in terms of patient presentation, how do patients with chronic rhinitis usually present to you?
Yeah, so chronic rhinitis, what it means is inflammation of the nose, right? So there's a few kind of cardinal symptoms for it, but it's really a pretty wide range of disease processes that all present with it. So the main symptoms that people get are chronic nasal blockage or congestion, chronic nasal drainage or discharge, itchiness, sneezing. Those all play into it, right? There's a lot of patients that I see that have this disease, especially because of my practice I just see rhinology patients, so it's very focused in on that disease process. And so vast majority of the patients do have some component of chronic rhinitis. Even those with like chronic sinusitis, a lot of times they have downstream rhinitis due to the chronic sinusitis.
Yeah, I would imagine in a practice like yours, it's every patient.
Pretty much.
Essentially, like you're not having to like screen for them among, patients coming in with other complaints. Especially in a rhinology practice. It's like, let me guess, you've got stuffy nose, runny nose.
I know. I mean, every now and then we get an earwax patient, right? like every ENT, right?
You're like, what is this on my list today?
I'm impressed that earwax can make it into the rhinology practice. Good for you. Keep that
like
skill
a microscope?
Set up.
What is this microscope I have to use? I'll just give you the endoscope. We'll clean the wax out.
I do actually clean out waxes with the endoscope. Because I've already going to scope their nose because I already have nasal complaints. So if they come to me and they have some earwax, I just use a little camera, a little curette and clean it out.
Yeah,
fun.
Like, we got this.
That's awesome.
We got this.
Well, then you can record it and people love watching earwax,
exactly.
getting removed. So
I've actually done that a few times because every now and then you randomly pick up things, right? So I found a couple like middle ear masses or cholesteatomas, and I was like, I'll put a camera in there, I'll take a picture and send it to one of my otologists.
Yeah. Huh. That's awesome.
Endoscopic ears, it's a thing.
Yeah.
So back to our stuffy nose, runny nose patient. Can you talk to us about like your history taking? Are there particular questions that you always ask? Is there important things that, you kind of need to pick up on in the history? Yeah,
absolutely. So this is why I'm a huge fan of these like patient reported outcome measures, the questionnaires. Like the big ones that we use are like SNOT-22, total nasal symptom score, nose scores, right? Because essentially those questionnaires cover a lot of the questions I typically would ask. So things like nasal congestion, nasal drainage, discharge, postnasal drip, loss of smell, facial pressure or pain, all these kind of different questions are all on there, right? And so I have my patients fill them out in the preoperative area. And so when I'm walking into the door, going in to see them, I can take a quick glance at that questionnaire and I see a lot of the answers to all the questions I typically would ask. That allows me to start focusing in on the diagnosis a lot faster, asking more about like frequency, duration, severity, and try to address their specific complaints. But yes, all those nasal complaints are all really important. So that way you can screen every single one of your patients.
How often is rhinitis so bad that it's affecting quality of life or use of CPAP, work, productivity? Do those factors come into play? And are the surveys covering some of those questions?
Absolutely. So yeah, there's a lot of questions out there about like loss of concentration, difficulty sleeping. I think that's a huge thing right now, right? Somehow sleep has become like the cultural zeitgeist moment right now for patients. Like everything, even though I don't do any sleep surgeries, inevitably I end up addressing their sleep complaints. Right, because a lot of them talk about how hard it is to fall asleep, not being able to breathe through their nose, how that mucus dripping down into the throat really clogs their ability to sleep. Right, and so I think that all that other aspect is super important. But I do think about I read a couple of reports. I think they estimate somewhere around like 30% of the population in all of the U.S. have some form of chronic rhinitis. Right, but the reason why we don't see it as much in our clinics is because so many people self-treat, right? So a lot of the medications for treatment of chronic rhinitis are all now over the counter. Things like Flonase, Nasacort, Rhinocort, all those allergy nasal sprays, right? So by the time they actually come in and see me, that usually means it's already bad enough affecting their quality of life, right? Where they're constantly thinking about it, that difficulty to breathe through their nose is making it difficult for them to exercise, or that drainage really interrupts them, or like socially embarrassing for them. Right? A lot of like patients, when they talk about like when they go out and eat or when they hang out with their friends, they feel embarrassed because they're constantly blowing their nose. Right, so I do think a lot of it, by the time they make it to see me, it's already heavily affecting their quality of life.
Yeah, I like to check out the cold and allergy and aisle at the pharmacy because it just keeps getting longer and longer, and I like to see like what patients are being offered.
Yeah, exactly.
Well, it just I think it's helpful to kind of see what all is out there because it is overwhelming. I think even more and more, I find that patients benefit from, even though things are over the counter, we talk about, okay, this one is good for this symptom and this is when you would take it. And this, this is good for this. And that way it just helps them kind of navigate a pretty intimidating list of possible over-the-counter medications.
Absolutely. Yeah, you're totally right? And if it's overwhelming for us, can you imagine how much more overwhelming it is for our patients who don't know like the mechanisms behind all these different nose sprays? They're essentially just randomly choosing and trying to figure out which one's going to work for them. And it's hilarious because so many of them have overlapping medications, right? They just go under different brand names. I really feel for our patients who suffer from this disease process, because I feel like they end up in this medical hamster wheel, right? They first go and see their primary care physician who start them on like intranasal steroids, maybe intranasal antihistamine. They then go see their allergist who start them on like an oral antihistamine or like a anticholinergic or something more advanced. Then they end up seeing us, right? And we're like, oh, have you tried like Flonase? Have you tried an intranasal steroid, right? And so I feel like our patients, they're constantly in this hamster wheel of this medical care. And so this post-nasal nerve ablation really gave us the opportunity to get them out of that hamster wheel, to offer a procedural intervention when the medications aren't working.
Yeah. And just in case there's someone listening who hasn't heard of PNN ablation, can you just, talk about what that is? Because we didn't do PNN ablations when I was in training.
Yeah.
So it is possible that there are people out there, if you've been in private practice for a while, who may not have heard of this kind of technique.
Yeah, absolutely. Absolutely. So what the postnasal nerve is, it's the nerves that carry the parasympathetic supply to the nasal mucosa. Right. I'm going to bring us back to medical school for a little bit. Right.
Let's go. Let's go back.
Yeah, exactly. Right. Back to the good old days. Right. So how parasympathetic supply ends up in the nose, it actually goes along the cranial nerve 7, right, next to the ear. It then jumps off through a nerve called a greater superficial petrosal nerve. Right. And then that goes towards the nose. It actually joins in with another nerve called the deep petrosal nerve from the internal carotid artery. That deep petrosal nerve carries the sympathetic nerves, right? So both the parasympathetic and sympathetic join together, and that forms the Vidia nerve, otherwise known as a nerve of the pterygoid canal, right? So there's actually a procedure that I used to do, or actually still occasionally do, where I go in and cut the Vidia nerve, right? And so that it completely stops that parasympathetic supply to the nose, really stops a lot of that drainage and discharge and that swelling that's being triggered by the autonomic nervous system, right? The big downside of that procedure is about 20 to 25% of patients will now get dry eyes, serophthalmos, right? Because that same nerve that carries the autonomic nervous supply to the nose also carries it to the lacrimal gland. And so someone really, really smart, much smarter than me, back in like the early 2000s, discovered that this nerve, once it goes into the pterygopalatine fossa, that's where it connects with the postganglionic fibers, right? And so by then, the lacrimal nerves now shoot off from there. And then the rest of the nerves then go back into the nose, and those are called the posterior nasal nerves, right? And so we find that in the lateral portion of the posterior nasal cavity. And then those nerves are primarily now postganglionic parasympathetic supply just to the nasal mucosa. So by ablating that, by addressing those or lysing them, now you're able to dry out the nose, reduce the swelling without any effect to the lacrimal gland.
There you have it.
I know. A lot of anatomy. Yeah. But that's what surgery's all about, right?
That was great. Hopefully people that got out their old, anatomy books kind of, followed it through.
Are these drawings in Netter? I don't recall them, but
I still remember that moment in medical school, right? When I was going into ENT and realizing that Netter wasn't enough. Right? Because once you start studying the ENT, right, the Netter diagrams are just a little bit too broad. It doesn't specifically, it's not detailed enough for ENT. So yeah, that was a big wake up moment. But there's been actually a lot of advances in our understanding of that nerve, even ever since then. Because back then, I think they just showed a couple of the nerves along that lateral surface. But as people have gotten more interested in this nasal nerve ablation or lysis, right, what they've done more anatomical dissection. And what they found is that rather than just a single nerve, it's a whole there's a whole group of them, right? And those nerves would come out pretty much in a pretty random distribution in that lateral wall, right? It comes out in the middle meatus, comes along that lateral surface. Some come out from the inferior meatus as well, right? And so although that video neurectomy was a very clean surgery, right? It was very nice. It was effective, but it had a lot of downsides. When it comes to this posterior nasal nerve, it's a lot more of a distribution of nerves, right? So it's not quite as clean. So that's why I think it's so important to make sure you try to hit that area as much as you can in the hopes of hitting one of those nerves.
So how do you decide when you see a patient who's ready for this? Do you have them try, like, is there a certain amount of time you want them on the nasal steroid spray, or is ipratropium part of your repertoire, or who do you recommend it to? And what do you want them, how do you know you've maximized medical options?
Yeah, exactly. That's a great question. Right. And that is definitely the key question when it ever coming to counseling any patient about a procedure, right? Try to figure out when is it the right time to elevate them to that next level. And so if a patient has CB and they're completely medication naive, I do usually put them on some medications first, right? And I kind of tell them what our evidence shows, that using these consistently is better than sporadically. Right, the BID dosing tends to be superior than just a single day, once a day dosing. And as far as time frame, I don't think we have much knowledge or much evidence of when is sufficient amount of time, right? But I think most of us will at least try it consistently for at least a month, right? That's what I consider a good solid medication trial. I don't have any good evidence for why a month, right? But that's just the time frame in my mind that makes sense. I do primarily put people on like intranasal steroids, intranasal antihistamines, especially if they have an allergic rhinitis component. The ipratropium bromide, that is anticholinergic, right? So theoretically, what it's supposed to do is go back and suppress those nerves that is causing that parasympathetic overdrive. Now, I do try it on every patient. When they respond to it, I tend to be a little bit more hopeful that they're going to respond to the procedure, right? Because that, in my mind, makes sense. So if it's calming down the nerves, by ablating those nerves, then obviously it's going to have that same effect as the ipratropium bromide. However, it's not a rule-out medication for me. So if they don't respond, that might be a couple of things, right? It might be that the nerves are too far in, that the nose sprays aren't reaching there, right? Or it might mean that they might have a different kind of mechanism that's going on inside the nose. So I still have, even if in patients who use the ipratropium bromide and don't feel like they respond, I still have some of those patients respond to the nasal nerve ablation. But I think in general, I first try the medical therapy first, right? And see if they have sufficient relief. And then from there, that's where the conversation turns into much more of a shared decision making, right? Because what I want to do is now sit down with the patient and try to understand how much is this really impacting their quality of life, right? I think in general, if the patient feels like it's kind of a nuisance, but not bothering them too much, then I usually don't offer any procedural intervention, right? Just because I want to make sure if I'm doing a procedure that we're maximizing the possibility that they're getting some kind of gain from it, right? But if it is still causing them significant impact on their quality of life, where it's causing them that social embarrassment or impeding them from exercising, or sleeping, doing their daily activities, and that's usually when I have the conversation to see whether they want to try this procedure.
Yeah. And just backing up briefly, as it relates to your physical exam, is there anything unique about what you're looking for? Or is it kind of like, all of us, we see the rhinitis patient a lot. So how do you, I guess one thing that seems to vary between people we talk to is whether or not you decongest the nose when you're looking at it.
Oh yeah. Yeah. That's a great question. All right. So I used to do lidocaine and oxymetazoline Afrin on everyone for my scope examination, and then something called a pandemic happened, right? COVID happened, and where there were all these concerns about like aerosolization. Yeah, it was a small thing. I don't know. Something you might have missed it.
Little blip.
Yeah. And during that procedure, we kind of learned how to do these nasal endoscopies on patients without using decongestions or topical lidocaine. And actually, I've found that actually has been really helpful in my diagnosis, right? Because in the past, anytime you decongest someone, everyone knows looks wide open, right? But now that I'm scoping people without that decongestion, now I can see exactly what it looks like, how swollen those tuberculosis are, how edematous mucosa is. So I think it's actually really improved my ability or how much what I'm catching on that nasal endoscopy. So everyone has these posterior nasal nerves. So as far as anatomical, as far as like who's a candidate, who's not a candidate, I think it's the physical examination is a little bit less important. But there are certain things I kind of look for that kind of help determine, that kind of weigh in on that decision making, right? If I look inside the nose and I just see tons of mucus, tons of edema and swelling, a lot of times that to me means that, okay, this might be someone that may benefit from the procedure, right? If I look at it and the nose just looks super clean, then we have to start looking for possible other etiologies of that nasal congestion, nasal drainage, right? Whether it's like reflux or something else that might be contributing. The other thing that the physical examination helped me with is figuring out where to do this procedure, right? I do this procedure both in the operating room and in the clinic, right? So if someone has a pretty easy anatomy, then I usually offer the in-clinic version, because I think in general, patients kind of prefer to avoid general anesthesia whenever possible. But if they have really tough anatomy, things like a really widened middle turbinate or really severe septal deviation, I do put a strong consideration into doing this in the operating room. A lot of it is just kind of determining how well the patient will tolerate it, right? I'm sure you've all had this, where you put a scope in someone's nose, you haven't touched anything, or you're even just getting close to the nostril and the patient's already jumping out of the seat, right? Those patients are not a good patient for an in-office procedure, right? But if they are pretty stoic during the procedure, if they tolerate the endoscopy pretty well, then in my mind, that's a great patient where I can offer an in-office version.
And just backing up still, Dennis, in terms of your allergy patients, do you want them to have tried like immunotherapy for a while? Do you counsel those patients a little bit differently than your non-allergic rhinitis patients?
Yeah, that's a great question. So we had the privilege of working with a lot of different allergists in the area, and they're all really, really great. And so it's someone that presents to me with like allergic rhinitis, I always tell them is you're the patient where I'm partnering with the allergist, right? The allergist, they take care of the inflammation, the allergy components of it. What I could take care of is the anatomical portion of it, right? And so when it comes to the discussion of immunotherapy, I really leave that up to the allergists, right? To have that discussion to see whether it's going to be effective for this patient and how long to try it for. You know, as you probably know, the allergy immunotherapy takes a long time before it starts working, sometimes years, right? And so if the patient's really struggling, and even if they are already on allergy immunotherapy or maybe just started it, I may still offer this procedure just to see if we could expedite some kind of response, right? Because they're struggling now, right?
They're still going to have a couple of years.
Yeah, exactly, before they start getting the benefit, you know? So I want to do something that might be able to offer them some benefit or some improvement in the quality of life.
Yeah, it doesn't have to be either or. It can be
exactly.
and.
It could be both.
Yeah.
And for your patients that also present with chronic rhinosinusitis, we said a lot of them will also have postnasal drainage and nasal congestion. They might also have a scope that has some edema and swelling. How do you distinguish how much is the difference between the two, chronic rhinitis and chronic rhinosinusitis? And then how do you know how much the chronic rhinitis or maybe the CRS is contributing to the postnasal drainage? Like, how do you think about those? And right? Do I need to do a posterior nasal nerve ablation if the issue is CRS? And how do I know?
Yeah, exactly.
Right?
Exactly. And that's so hard to tweeze out, right? Because they're so interplayed. You know, because anyone that has chronic rhinitis, a lot of times what we know about chronic rhinitis, chronic rhinitis, this is a little bit different from acute recurrent sinusitis, right? So chronic rhinosinusitis, what we know is that it's much more of an inflammatory issue, right? For some reason, they have some overdrive in their system, which is causing a lot of inflammation, and that presents as inflammation inside their sinuses. And downstream of that, what that causes is inflammation inside their nose. Right? Because the main symptoms we're looking for chronic rhinosinusitis are nasal congestion, nasal drainage and discharge, loss of smell, facial pressure and pain, right? And you can see those first two symptoms heavily overlap with chronic rhinitis. Right? And so probably a lot of those patients who have the chronic sinusitis downstream is causing that inflammation inside the nose itself, leading to that nasal obstruction and drainage and discharge. Right? So I do think a lot of people do have that interplay. And we know that doing chronic sinus surgery does help a lot with their rhinitis symptoms as well. So I think your question that you've landed on is really, really key. When do we add that extra nasal nerve ablation procedure to the sinus surgery? For me, I think it all goes down to what symptoms are bothering them the most, right? Is it more the nasal, the loss of smell and the facial pressure or pain? That tends to be much more from the sinuses, right? The nose itself doesn't cause too much of those symptoms. But if it's more the obstruction and especially that drainage and discharge, right? Because I've definitely have had patients. I remember early on in my career, like this very, very key moment when I had my first quote unquote kind of like patient who I did surgery on, good surgery on, and then came back still with complaints, right? And how crushing of a feeling that is, right? Because here you are, I just finished fellowship, I did the subspecialty training in sinuses, right? And so I feel pretty confident in my surgical abilities. I took care of the sinus disease, yet the patient still feels miserable, and so that's soul crushing, right? And so now
nobody teaches you that.
Yeah, exactly.
Nobody teaches you that.
Exactly. Yeah. So now I try to tweeze out how can I maximize the potential that this patient is going to benefit from surgery, right? Because here they are, they've already taken time off of work, they've already invested their time and money into committing to a surgery with me. I want to make sure that the patient gets a maximum benefit from that one procedure. Right. And so if someone comes to me and they have a lot of issue with that drain and discharge and that congestion, then a lot of times I do consider doing something simultaneously to those posterior nasal nerves to kind of maximize that benefit, right? Because the procedure itself is relatively low risk. It's pretty, and it doesn't really add much to the recovery time.
And when I think about the areas that are treated when you do like a PNN ablation, and I think about some of the other surgeries we do in ENT, do you think that there are some times when we are kind of treating the nerve and not knowing it?
I'm sure.
Yeah,
100%, right? Because
before we were thinking about the nerve, maybe some patients were benefiting from their procedure also because of, maybe some nerve branches got hit.
Especially if you do a wide maxillary enterostomy, right? You're already cutting part of that lateral wall where some of the nerves are going, right? Especially posteriorly. And so I'm sure you're cutting some of those nerves. And then you're addressing, especially if you do turbinate surgeries, right? You're addressing the end organ, right? The organ that's being stimulated by those posterior nasal nerves. So yeah, absolutely. We're definitely addressing it in some capacity, even before we had this procedure specifically for the nerve.
And so I guess let's talk about the procedure itself. I mean, we have somewhat, but, in general, kind of backing up a little bit, there's a few different tools available to address the posterior nasal nerve, and then we can kind of get into specifics.
Yeah, absolutely. Yeah, you're absolutely right. So there's a couple of different devices out there on the market to address that nerve. There's kind of three primary ones, right? There's the Rhinitis, which is the radiofrequency ablation. There's the Clarifix, which is cryotherapy, so that's freezing the nerve. And then there's the Neuromark, which is also a radiofrequency ablation, except the device looks a little bit different, right? And so with the Rhinitis, it's a single probe with a malleable tip, so you could be very, very precise with it in addressing multiple in those locations where you think the nerve might be. With the Clarifix, essentially it's a balloon that blows up with, I believe it's nitric oxide. Right. So that freezes the surrounding mucosa and the nerve underlying it. And with the Neuromark, it's also radiofrequency, but rather than a specific probe, it uses kind of it almost looks like leaves, like a little basket, right there, where it kind of all those leaves should theoretically touch that sidewall and hopefully maximize the chance of you capturing that nerve. So definitely pros and cons of each approach, right? I think the Rhinitis, it's very malleable. You can guide it exactly where you want it to be. I think the Clarifix, it is very effective. It's faster, right? However, the downside is about 10% of patients will get this really severe ice cream headache, right? And this ice cream headache, it can be pretty bad. I've tried a lot of different things to kind of prevent it. I've tried having people sip on warm teas, tried warm liquids. There was a paper that actually I think Dr. Su, he was on your podcast a little while ago.
He was.
Yeah. He wrote a paper mentioning gabapentin. You had people take that before the cryotherapy. I also tried that as well. But despite all that, no matter what I try, a certain population still seem to get those ice cream headaches. Yeah. And it's not just do you remember if you eat ice cream and you get that brain freeze, or for me it was
it's a couple of seconds
back then when it was a thing, right? It would last for a couple of seconds and it would go away, right? But for this one, it would last for hours sometimes, right? And that could be really excruciating for the patients, But I do think it is very fast and efficient. So I still occasionally do the cryotherapy as well. And then the neuromark, it is faster than a Rhinair because you do like a single spread of those leaves. However, I think the one advantage the Rhinair has over the neuromark is that being able to address other structures at the same time, right? So Rhinair, not only can you do the posterior nasal nerve, but you can also do a turbinate reduction at the same time and do a septal swell body reduction at that same time as well. So you're able to address 3 anatomical issues in one procedure.
Can you go into the swell bodies and the turbinates? Because, this is going to show my age, but the swell bodies, never had that discussed until probably the last 5 to 10 years. I don't know. I mean, how often do you feel like addressing the swell bodies is necessary? And does it help with the rhinitis? Is this more of a nasal obstructive thing? And how often do you need to address turbinates for chronic rhinitis as well?
Yeah, it's very, very fascinating because I think so when you look at the history of the septal swell body, right, there were some actually publication in like the 90s or so that kind of...
I just didn't read it, Dennis.
Yeah, no, totally. Well, we were aware of it because we couldn't do anything about it, right? Like there wasn't a procedure to address it, And so like with everything, that things that you can't address get ignored. Right?
Yeah.
And so, but now that we do, that's why I think there's been this increasing interest in septal swell bodies. People used to call it the septal turbinate, right? Because if you histologically look at what that septal swell body looks like, what you see is venous sinusoids and mucus glands, just like a turbinate, right? And so it's also a erectile tissue, just like a turbinate, and produces a lot of mucus, just like a turbinate. Right.
And you can decongest it, right? You can decongest it just like a turbinate. Yeah.
That's correct. And so, you see them on your CT scan all the time, right? You see
it gets in the way for FES sometimes, right? To kind of medialize that middle turbinate. That's what I think of, like that area that you just can't always...
Exactly.
It gets in my way.
Yeah, exactly. You're annoyed by it. Right?
So annoying. I'm like, what do you want me to do with this? Can I just buzz it? Like, I don't know what to do.
Exactly.
You need to be able to see.
And so when you look at those CTs, you see those cuts kind of right near the piriform aperture, the bony open. You see this almost like an hourglass shape, right? And then that's that septal swell body, right? And it really differs from patient to patient on how big and how obstructed it is. There are actually some papers out there kind of trying to figure out when that septal swell body is the source of your nasal obstruction. So there was a study where they would put Aerin on the little cottonoids or cotton balls, and they would put it right at the septal swell body and allow that septal swell body to decongest and to see, okay, is it before or after, how much improvement did they have, right? And so when they noticed that was significant, then they used that to determine that the septal swell body was a major contributor to their nasal blockage. And so I don't do that in my practice, but I think it is something. If I had more time with my patients, maybe I would.
I was going to say.
Right? If I had like an hour-long visit, right, as opposed to like 15-minute visits. But I think what that was telling me is that, okay, anytime I'm addressing the turbinates, I probably should think about addressing those septal swell body too, right? Because just like the turbinates, they could swell up, and just like the turbinate, they could produce a lot of mucus.
Okay, so anything else that we need to cover about the technology itself as far as radiofrequency goes with Rhinair? It's temperature controlled, so it's not like burning the tissue.
Yeah,
right?
Exactly. So it took me a while to figure out my talk track when talking to patients about radiofrequency. I remember.
I agree.
No, totally, right? I remember one patient specifically when I was describing it, he was like, "Wait, so you're going to microwave my head?" Right? And I was like, "No. Well, kind of, right? So radiofrequency, what it is, it's along an electromagnetic spectrum, right? So just like a microwave, except the wavelength's a little bit longer. And the idea here is that you're using radio waves to deliver energy. Right. So kind of like, your phone, we have all these like MagSafe chargers now. Same idea there, right? You're using something along the electromagnetic spectrum to deliver energy to charge your phone. In this case, you're kind of charging your nasal mucosa or those nerves, right? And so the nice thing about the technology for the Aerin device, it's temperature controlled. So it hits 60 degrees Celsius. Now, I find it very fascinating because I've been in the medical field for a while now. So I'm pretty good with the metric system, especially when it comes to like weight and length, kilograms, meters. Those are very intuitive to me. Yet for some reason, a Celsius is still not very intuitive to me. Like
I have to calculate that.
Exactly, right? I have no idea what that means.
I think that's really hot. Yeah. I don't know.
Yeah, exactly. I feel like it's going to be pretty hot. So what it is Fahrenheit is around 140 to 150 degrees Fahrenheit, right? So if you ever go to your oven and go to like the keep warm setting, right? That's right around that temperature range. So you're keeping it warm, but you're not quite cooking yet, right? And so the idea behind this, why that temperature was chosen, is because now you're applying energy, but you're not causing thermal necrosis. You're not burning, right? And so that's kind of the idea, to more minimally invasive, in a less severe manner, deliver that energy to interrupt that nerve supply without causing damage.
Yeah. And I think when you're doing the procedure, you see that, like, because you don't see char like you would, like when you're coagging, it's just kind of, sometimes it's kind of hard to even see where you treated.
Exactly. You see a little bit of blanching, but no char. Yeah.
Right. Are you seeing physical decrease of the tissue?
What I see blanching, right? You can see that that there is some reaction in that mucosa, probably like the capillaries constricting down and things like that. But yeah, you don't see the necrosis. You don't see the burn damage. And then after the procedure, you do see a little bit of crusting as it's healing up. But the crusting is almost always pretty mild, and it goes away after a week or two.
And so for this procedure, you talked about doing it in the OR versus doing it in the office. Briefly talk to us a little bit about anesthesia protocol when you're doing it on an awake patient.
Yeah. So everyone has their own variation, right? And so I always tell people, figure out what works for you and then do that, right? Because you'll have to copy what I do. So what I do is I'll first start with spray. So topical numbing, right? So I spray them with topical lidocaine and topical oxymetazoline. I then soak little cotton pledgets, those little rectangles with tails on them, in that lidocaine and oxymetazoline, and put them in right where I'm going to do that nerve ablation, right? For a while, I used to do cotton balls. I actually really like cotton balls because they expand and they get they applied that topical in a 360 manner, while those pledges are a little bit thin. But I had one patient who sniffed in a little bit too hard and ended up swallowing his cotton ball. Right. And so ever since then, I was like, okay, I'm just going to switch back to these pledges.
No one gets cotton balls. They ruined it for everyone.
I know. It's a little bit, he got a little extra fiber in his diet, so.
That's funny.
Yeah. So I'll do that. So a couple of key things that I found. One of the most important things is I will anesthetize that nasal valve too, right? And so we're not doing anything to the nasal valve with this procedure, but a lot of our cameras, a lot of our instruments is passing in and out right next to that nasal valve. And so I've actually had patients complain about the camera pushing it against that valve more so than the instrumentation itself, right? So I do anesthetize that area so that way they're nice and numb.
Topically?
Just topically, yeah.
Okay.
Just for patient comfort.
There. Yeah,
exactly.
Okay. Cool.
And then I do still do injection. Now, there's a lot of people who don't do injections anymore for this procedure, but I still do because I think it does offer a little bit more anesthesia. I'll do an SPA block, right? And so I'll inject there and inject along that lateral wall, along the turbinates, along that septal swell body. The downside of that is you do get a little bleeding when you're injecting,
right?
Because otherwise it's pretty bloodless procedure. Mm-hmm. But I think for me, it seems to benefit my practice. Some other things to do that I do. This is how you know I practice in Southern California, right? I do a couple of non-medicated anxiolytic practices, right? So when I have the patient come into the room and I'm talking to them about the procedure, I actually have a lavender aromatherapy kind of going at the same time. There's a lot of good evidence out there that lavender aromatherapy seems to help with procedural anxiety and pain. And so while we're discussing, they'll be breathing in that lavender, hopefully calming them down a little bit. I'll do some music therapy as well, right? And so I'll have some music playing in the background, so that way they have something to distract themselves, something to help ease their anxiety. And then I'll dim the lights.
Music?
I leave it up to the patient's choice, right? Whatever they feel relaxing, right? So some of them like spa, some of them like classical music, some of them like hard rock. Right,
I was going to say, I let a patient pick one time, and he picked Metallica, which was not very relaxing for me. Trying to do a procedure on him.
Yeah, I had a patient pick 9 Inch Nails. Right,
that's too funny.
But again, what we're treating is the patient, right? Not
true.
necessarily the physician.
It's
right?
not about me.
Yeah, exactly. It's all about the patient right now, right? And so I think all these things kind of make it a little bit easier for the patient. So after implementing all these, it's been 3 years since the last time I've had to prescribe a oral anxiolytic for a patient.
Oh, really?
Right? So yeah.
So you don't even do like a Valium or Triazolam or anything?
I used to, but by integrating some of these other things, patients seem to do fine without it. Yeah.
What was do you feel like it just makes them too sleepy, or it's not worth the risk, or you want them to be able to drive themselves, or what was the thought for moving away from it?
I just like to, I think in general, if we can avoid using anti-anxiolytics, that's always preferable. But the biggest one was the driving to and from the procedure, right? So if they did take the Valium or something like that, then obviously they would have to find a ride, which kind of goes in contrast of doing the in-office version, right? Because in-office is all about convenience, and that makes it really inconvenient. Yeah.
Yeah, that makes sense. And when you're doing the procedure, you mentioned you use Rhinair a lot. You're putting that little paddle kind of right there in the posterior middle meatus. Do you treat posterior to the middle turbinate?
I do. There was actually that also came in from some of those anatomical dissections, right? Where they found not only was a nerve anterior to the senopalatine foramen, right? But there was also nerves going posteriorly and past the choana into the nasal pharynx as well. Right? And especially people with bad postnasal drip. I don't have evidence for this, but I'm convinced that probably likely where there's a lot of irritation going on more posteriorly. So by hitting those nerves, hopefully we can minimize that postnasal drip symptom.
Does your handpiece allow you to get to all of these places?
Yeah.
Like when you need to get posterior to the middle turbinate, I would imagine you got to make maybe like a different angle or a bend, or
exactly.
How does that work?
Exactly. So with the older version of the handpieces, that Rhinair handpieces, it used to be pretty immalleable, right? And so it was really hard to get to do a full ablation. But with the newer version, now that shaft is a lot smaller. It is now much more malleable. And so now whatever anatomical variation the patient presents with, you can usually mold that handpiece to fit it. I've actually done a couple with pretty bad septal deviations as well, right? So previously, the people with bad septal deviation, I used to just do them in the operating room. But I've had a couple patients who really, really did not want to go to the operating room. And so I told them, well, we can try, right? And they were good candidates. They were very stoic with the endoscope. So I used that handpiece. I kind of bent it in plane and out of plane, right? So it almost looks like a little bit like a S. Right, and I was able to still get that handpiece into where I needed to go with it.
That's awesome. Okay, as far as bleeding, is there very much bleeding to worry about when you're doing the procedure in the office?
Yeah, so I think that's one of the nice parts of this procedure, right? There's no incision, there's no cuts besides the injection you might be put in, and so I've not had an issue with the bleeding during the procedure. There's a couple of publications out there that shows some people have had some late bleeds, like 3 weeks out, some posterior epistaxis, but overall it seems pretty rare, right? And so it was
like what, 2% or
something like
pretty
that.
low.
I don't remember the exact number, but it was pretty low. It seemed pretty equivalent to like sinus surgery, septoplasty surgery. All of them have like a pretty similar bleed rates. Yeah.
But it's like 3 weeks. I mean, it's pretty far out and potentially a pretty fast, bleed. So I guess, do you talk to patients about like, okay, if you have a nosebleed, don't just let, don't go to the ER and have somebody put in like an anterior rhino rocket, because that's probably not going to clean care of it.
Exactly. I mean, it's the same talk track I give all my patients who are undergoing any kind of procedures inside the nose, right? If they have a bad nosebleed, definitely contact our office, let us know, make sure that whoever's on call is aware of it, right, and can potentially evaluate. Now, this is one of those situations where it's probably better to be lucky than good, right? So I've not had a posterior nosebleed, even though I've been doing this procedure for years now. And so hopefully that streak continues.
Do you avoid any areas, or is that really not because it's all the same area?
I do avoid applying it directly to the senopalatine artery, right, where that artery kind of comes out. And you could kind of see with your endoscope where you can see approximate where that foramen is. So I avoid apply it directly there, right?
Well, maybe that's why you haven't had a nosebleed. There you have it.
In terms of using this technology, is this something that you used in your fellowship or your training, or is this something that you started when you got out?
This came out right during my fellowship year. So it was something that I didn't have much exposure to. I think I did like maybe 1 or 2 Clarifix procedures in my fellowship year. I didn't do any of the radiofrequency because it wasn't quite out yet. Yeah, so it was all something kind of learned post training, right? But I mean, I think this is what makes ENT interesting, right? Because the fact that the field is always evolving, right? There's new techniques coming out. There's better techniques coming out. It's nice to not see stagnation.
Yeah. And just as far as like scheduling logistics, about how long does a procedure take you? And do you like to, just have a procedure day with all your office procedures? Or is this something where you can have it kind of in between clinic patients that you're seeing? How do you like to schedule it out?
Yeah. That is a great question. Now, there's what I would like to happen, and then there's what actually happens, right? So what I would like to, so I do have a procedure day where I just do procedures. I usually book out 1 hour. That's more than enough time, right? But it's nice to have a little bit of buffer, right? And so, but however, especially based on patients' availability and my availability, sometimes I will be doing these a lot of times integrated in my clinic, right? And when it is integrated in my clinic, not uncommonly, I end up booking patients during that procedure too, which actually kind of works out. So what I typically do is I'll go in, I'll start the numbing, right? I'll put in the pledgets, and then I'll leave and I'll go see another patient, right? And then by the time I'm done with that patient, now I can come back in and actually do the procedure on the patient. No one's ever accused me of being patient, right? And so what this does is it forces me to give the topical time to work, right? And so, otherwise, like after about 10 minutes, I'm like, that's probably enough time. Let's go, let's get going, right? And so by going and seeing another patient, now I have that full 15, 20 minutes for things to work.
Yeah. For sure. Yeah. If you stand there in the room, like 2 minutes feels like
it's like an eternity.
It's like, it's probably
I'm like
good.
10 minutes. It's like 3. And I'm like, all right.
Yeah. I always thought hilarious because like during the ORs, you'll put like Afrin pledgets for like bleeding, and you'll leave it in for like 30 seconds, right?
Yeah. Like, let's check it. Like,
is this really enough time? Probably not. Right?
Yeah. So we talked a little bit about how there are some different devices, and I think I've even talked to ENTs who are using like even like laser or other devices that aren't specifically for PNN ablation. But have there been any like comparison between techniques? Like, do we know anything as far as like data?
Yeah, that's a great question.
Or is it all just kind of personal preference?
That's a great question. So there has not been a randomized head-to-head trial between these different technologies, unfortunately, right? But I was involved with the indirect treatment comparison, right? And so what the indirect treatment comparison is you're usually 2 different randomized controlled trials and comparing those two based on the fact that they both have similar placebo arms, right? And so when you compare the cryotherapy and the radiofrequency ablation, there was no difference based on the indirect treatment comparison as far as outcomes, right? And so I think in essence, what that tells me is they're probably pretty equivalent as far as outcomes. Now, the reason why I tend to favor the radiofrequency is so those treatments were just based off of posterior nasal nerve ablation, right? But the posterior nasal nerve ablation or cryotherapy, right? But what I'm able to do with the ablation techniques is I'm also able to address that inferior turbinate and that septal swell body simultaneously, right? And so in my mind, I do feel like, at least in my hands, doing that turbinate reduction and then septal swell body offers additional benefit to the patient's symptoms on top of just the nerve by itself. And so if I'm able to get 3 things out of one procedure, I think that's all the better.
Yeah, I think that makes a lot of sense too.
Yeah, totally.
Okay, and then as far as outcomes and how you counsel patients, when should people expect to feel better? What are you having them do, like some nasal saline irrigations afterwards?
Yeah, absolutely. So the recovery is pretty benign for these procedures, for both the cryotherapy and the radiofrequency ablation. Everyone does get a little bit of crusty. I do have people do like a sinus rinse, some kind of nasal irrigation to help clear it out. But they see me about 3 weeks after the procedure, and almost always, like all the crusting is all resolved by then. All right, so persistent long-term crusting has not been an issue with it. As far as how I counsel the patient, now this is the crux of the issue. Right. So I think this is really, really important because chronic rhinitis is a chronic disease, just like chronic sinusitis. You're not necessarily going to cure them from it. Everyone's always going to have some underlying inflammation, overdrive, whatever it is. Right. So that's how I counsel my patients as well, right? I tell them I'm not going to cure them, right? But what I'm going to do is going to take their severe symptoms and make them more mild, right? If you tell your patient you're going to cure them, they're probably going to end up disappointed, right? But if you tell them that you're going to improve their symptom severity, almost like 80 to 90% of patients at least experience some kind of improvement. So I think that's really important. And that pans out in the studies too, right? Because what you can see on the studies is that they go from a severe class to mild, right? They don't go to zero, they don't go to no symptoms, but they go from severe to mild. And so I think emphasizing that to your patients is really important, because that way they're kind of ready for what to expect, right? But I do think even though it's not necessarily curing them, it does help with their quality of life a lot. It also helps a lot with how medication dependent they are, right? I've had quite a few patients who were using all these sprays, 4 different sprays at a day, and now maybe just one as needed, right? And so I think that's a huge win too.
Yeah, that's a big drop, big difference.
People don't feel better immediately, right? And so that's another important part, right? If they expect to walk out from your procedure and be like, oh, I feel better, they're going to be disappointed. So I think the studies show somewhere around 4 to 6 weeks typically is when they start. Most studies, the first measure point is right around 6 weeks. So I tell them people usually by 4 to 6 weeks out is when you start noticing improvement. Yeah.
What percentage of patients would you say have had the procedure that go from severe to mild symptoms? Like, is that 80% of patients? How do you, 50-50, 95%?
Yeah, at least in my practice, it seems right around 80%. It seems to reflect what the studies seem to show. But I think that, again, that's all about patient selection, right? So if you take severe patients, about 80% will get improvement. If you only take someone that's moderate symptoms or even mild, then you're probably not going to expect that same drop, right? Because there's less room for improvement.
Are there any patients that you would say, you know what, the in-office radiofrequency ablation or cryo, you may not benefit from, you're going to do better with a posterior nasal nerve neurectomy? Anybody like that? Is there ever a time where, or is this like, no, this is the best option right now as for all comers? Or
I think in my mind, I think all the different technologies are relatively equivalent when it comes to addressing that nasal nerve, right? There are, if patients fail those, that's when I would consider maybe doing a Vidian neurectomy, but that's kind of my escalation from there. Yeah.
Gotcha. So you don't find much benefit over like doing like the endoscopic PNN neurectomy where people are kind of, elevating the mucosa and putting, like, I forget what it is, but putting something there to kind of prevent those nerves from going back.
Yeah, I think there's a benefit.
Too new?
I think there's a benefit from a billing perspective, right? And so the posterior, because for Medicare and Medicaid, they will cover ablation or cryotherapy, but a lot of, we mentioned previously, a lot of the private insurances didn't, right? And so a lot of those times when I found a patient who was unable to get insurance approval or the costs of the procedure. We have a cash pay option for patients too. If that cost is too high, a lot of times I will do the neurectomy because I could get that billed. It's covered by the insurance, right? That's kind of the only time I do it. Yeah.
Yeah. Okay. That makes sense. Okay. And then as far, you talked about 80% will improve. That means 20% maybe, don't have as good of a result. How many of those are you offering a revision, or is the conversation, well, maybe we need to optimize other medications or other things?
Yeah. 100% of the patients I will offer again. Right. And so, again, it's all about that conversation. So if they fail it, then I kind of tell them 3 different options, right? Option 1, continue the medical therapy, right? Try the nose sprays a little bit longer. Maybe look for some other things that were contributing. There's a good systematic review that shows the high percent of patients who fail chronic sinus surgery for chronic sinusitis actually have underlying reflux that might be contributing. And so that could be a potential for the chronic rhinitis patients as well, right? 2, I offer them a repeat procedure, either radiofrequency ablation, cryotherapy, something to address that nasal nerve again. 3, I offer that Vidian neurectomy, right? And so if it's severe enough, so that's the real key. I try to figure out how much does this impact your quality of life? Is it worth the additional risks, right, with that Vidian neurectomy? Right. So I have that conversation with every patient pretty much. And so I kind of leave it up to the patient to decide, okay, which route do they want to take?
When you're doing a revision, let's say we are going to do like revision, PNN ablation, are you hitting same area again plus a wider area?
Exactly.
Or, okay.
Exactly. I go wider, right? Go into that inferior meatus, go more posteriorly, try to maximize the chance of hitting that nerve.
And what's the timing? So when would you offer it? 3 months later, a year later? Like, how do you know?
Yeah,
when
another great question.
Failed? And
another question, which is data free, right? We don't have any information to tell us when to offer the procedure again. So in my practice, I just do 6 months, right? I think 6 months by then, you've had enough time to recover and go back to your new steady state. Right? And so, yeah.
And when counseling patients on longevity of the procedure, if they did have a good response, how long should they expect to feel better? And since we know that nerves can regenerate and come back, like if they start getting kind of stuffy and drippy in a couple of years, could you repeat it at that point? Or do you ever talk about that?
Absolutely. So what we know from our studies is that the 3-year data just came out, right? That's been published. And so we know for at least 3 years, people seem to maintain their symptom relief. So at the very least 3 years out, But again, those are large studies, right? Patient to patient, there's definitely a lot of variation. I've had patients who have done it once and now 5 years out, they seem to be fine. I've had patients who have done it and then maybe 2 years or a year out, then they start noticing some recurrence of symptoms, right? And so that's what I have that discussion with them to see, or do they feel like they want to repeat that procedure again or just continue the medical therapy. I think the one nice thing is as we've gotten a lot better at doing these in-office procedures, we somewhat normalize them, right? Now doing one of these in-office procedures, like when I first got out of training, doing it was a big thing, right? Like I had to block out time, like arrange all the medications, arrange my time, make sure everything's all packaged together. But now because it's become much more routine for me, it's like doing a debridement. Right, it's a lot less of a do, and then most importantly, the patients feel like it's not that big of a deal. Right, being able to come in, pop in, do this procedure. It's like going to a dentist and getting a filling. Right, it's not as big of a thing.
Cool. Okay, let's talk about billing as we round this out. At the top of the show, we talked about Cigna covering PNN ablation now, and you mentioned that you're typically going to treat the posterior nasal nerve, septal swell bodies, and the inferior turbinates. And so talk to me about how you bill the different procedures, like some kind of pearls as it relates to that.
Exactly. So the billing with those 3 anatomical issues, there's 3 codes that you could bill, right? So for the posterior nasal nerve ablation, that's going to be CPT 31242. For the inferior turbinate, it could either be 30801 or 30802, right? 30801 is superficial radiofrequency ablation. The 30802 is intramural. There's been a lot of debate on which one's the more accurate one. And it seems like the conclusion is both of them are reflective, right? Because that radiofrequency is being, even though you're applying on the surface, it's getting transmitted intramurally. So you're still doing an intramural ablation or reduction. And then for the septal swell body, that's going to be 30117, which is destruction of intranasal lesion, right? And so 3 different codes, the 30117 and then the turbinate codes, they've been covered forever, right? So those have been a long time. The 31242, that's the new one that's now being covered by Cigna Insurance. It's now effective September 15th. So in another 2 weeks, another 2 weeks it comes into play. The nice thing about this is it's not bundled, right? So you bill each one of these procedures, each one of those codes separately. And so you potentially get 3 different codes reimbursed in one go.
And the codes are, it's bilateral. Like you don't add
bilateral. You don't add a 50
You don't bill
modifier
for each side. It's just assuming that you're treating both sides.
That's correct. So they are now, their official ruling that it's no longer considered experimental, right? But you still need a justifier, right? So make sure you document clearly in the note what medical management you've tried and which ones have failed, and then discussing why the patient needs this procedure. They don't actually specify exactly what's needed in that documentation. So again, it's a little bit nebulous, but we're very hopeful, right? And so hopefully once they...
You haven't started the peer-to-peer calls yet.
Exactly. But it does seem like that they're going to, theoretically, it should be processed without issue per the Cigna website. So we'll see. I'm hopeful though. There are some things that are available as well for that. The Aerin is actually came out to help support this transition. Aerin has this thing called the Aerin Reimbursement Center. It's a complimentary service where they will work with your schedulers, with your rest of your team to try to figure out how to get billing, making sure they're submitting the correct paperwork and everything like that. So that's been really great because it's a service that Aerin offers. The second is Aerin now offers a Cigna Access program. So from September 15th to October 15th, any one of these claims for Cigna, the Aerin will help you through it, and they will provide a invoice credit if it is denied or if it's underpaid compared to what it's supposed to be. And so additional service just to help ease us into this transition period. Right. The reimbursement for Cigna seems to be pretty favorable. It very much varies depending on your contractual payment and then from state to state, but it seems like on average right around $3,400 nationwide.
And for the patients who don't have Cigna, is that just like you might bill for the inferior TURBs whole body to the insurance and then you have like a separate cash option?
Yeah,
or
exactly.
Is that kind of how you've done it in the past?
Yeah. So there's been a bunch of different ways we've done it, right? And so one, we've just done it straight cash. Two, we do a split billing, like kind of like that, where I get part of it covered by insurance, part of it by cash. So it very much varies from insurance to insurance and from patient to patient.
Yeah. What's your cash pricing?
It's right around $3,500.
Do you know off the top of your head? Okay.
Yeah.
Because I mean, I think patients, there are some patients, who have an insurance that's not covering it, but who are so miserable that they're just like, what do I need to do? Let's do this.
Please do something.
And I think that around $3,500. Yeah. Right around, right around there. It's like a lot of people's deductibles, right?
Any future changes or research or innovation that you see coming up for posterior nasal nerve ablation or the management of chronic rhinitis? I don't know, as we start to round things out.
Yeah. I mean, I think this is a very exciting area right now. Again, these are patients that we did not have a procedure for, or not a great procedure for 5 years ago, but now we do, right? And so it's another area where we can really benefit the patient. But it's also an area that's still in its nascency, right? So there's still a lot of research on how to improve your techniques, how to improve potential outcomes. There's also a lot of development from different companies. It's nice to see that there's competition in this area because hopefully that drives more innovation. Better technologies, better devices that can make the procedure easier and more effective for our patients. So I think it's a very exciting time to be involved with chronic rhinitis. I remember talking with an allergist once that we work with quite frequently. And when he found out I was doing this procedure, it was like a eye-opening moment for him. Because in the past, he would hold on to these patients because he would send them to the ENT and we would do exactly what I mentioned earlier, where I'd be like, oh, let's try these nose sprays, which you've already tried on, right?
Yeah.
And so he found it was worthless referring these patients to ENTs. But now that we have a procedure, now he's sending us a lot more of these patients who might potentially benefit from it.
Awesome.
Well, this has been so fun, Dennis. Thank you so much for taking the time to sit down with us today. Any parting words for our audience? Anything that we didn't cover?
I really appreciate you guys having me on the show. I think the biggest thing for those audience members listening is just give it a try, right? Like if you've not done one of the posterior nerve ablation, give it a try. Be mindful of your own results. See how it is in your own hands, and hopefully you get the same experience as I did, where you get some few wins and you start doing this more and more, and realizing that you're able to really change people's lives.
Dennis, are you on any social media if anybody wants to reach out to you, or they can reach out to you through us on the show as well?
Yes, I am not very active on social media. I do have a X account. It's Dennis Tang, MD, right? But I'm not very active on it. I'm really bad at social media. I probably should be better given this day and age, but yeah. Because I feel like we were the original social media crew, right? Like Facebook came out while we were like in college or like just immediately after. Right?
Residency.
Exactly, right? And so we were like really involved in all that pretty early on, but I don't know. I think I got burnt out from it.
Yeah, it was a different product back then, and it was exclusive. Once your mom got on it, it wasn't cool anymore.
I know. Well, yeah, exactly. Because back then it was just all about networking, right?
Yeah.
Now it's all about kind of showing off, which I'm just not into.
Yeah. For sure.
But I do think it's how our patients find us. It's how like the world finds us now. No one's looking at the word of mouth is a lot less
Yeah.
effective now, so I do think it is probably something I should get better at. Yeah, but thank you so much for having me on. It was a real pleasure speaking with you this morning.
Yeah, this was
Thank
great.
you, Dennis. Learned a ton.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.